Samir?
Yes, sir. Good evening.
Yeah, you have checked your presentation?
Yes, sir. Not here, sir.
Huh? Yeah, you can just see that if
Sure.
everything is okay, and then you
Okay,
can
okay. All
go.
right. I'll just share my screen.
Yeah, because we have 3 minutes still there.
Is it visible, sir?
Yeah, absolutely. No, this is yeah, first slide. Yeah, good, 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 good. Fine, fine, working.
Okay, sir.
So, good evening, everyone. Very warm welcome to today's smart learning program for agent. And it's indeed our pleasure to welcome and introduce today's faculty, Dr. Smith Trivedi, to all of you. Dr. Dr. Smith Trivedi at present is Professor and Head Department of Urology at the prestigious Institute of Medical Sciences, Banaras Hindu University, Varanasi. Academician to the core, he has more than 90 papers to his credit, which are published in peer-reviewed journals, both international and national. And also he has 8 chapters written on his from his contribution to different books. He's a reviewer in many journals, Q1 journals, World Journal of Urology, International Urogynecology Journal, BMC Urology, Current Urology, International Journal of Medical Research and Sciences, and Indian Journal of Surgery. Last year, he was awarded Economic Times Award for inspiring urologist in India, and he has been invited to many international and national conferences, the zonal meetings, and the state meetings. With this, I have a great pleasure in introducing Dr. Samir Trivedi to you. And today he'll be talking on a very important subject, urology cases. As you all know that how important is this sector, not only in terms of the theory questions you get on different issues related to urology cases, but as well as at least some case will be there in the practical exam also. So today, very intelligently, he discusses 3 questions where you may not be intervening, but still you need to work on the patient. In other situation where there are a number of options available to intervene this patient. And third option where the strategy is okay, well defined, but there are some sort of complications and some issues attached to that intervention. So with this, I welcome Dr. Sunita Reddy and Dr. Neil, over to you. We'll be having your lecture followed by a discussion from any question which comes in the chat box. Over to you, sir.
Sure. Thank you very much, sir. Thank you for that warm introduction. And it's a pleasure to be with all these young urologists who are going to be our future. And it's an excellent academic initiative. I thank Dr. Arun Chawla, sir, Dr. Keshav Murthy, Indian School of Urology. And is my screen visible, sir?
It's fine, fine.
Yeah. So the brief given to me for today's presentation is to talk about evaluation and management of renal calculi. And in order to avoid digressing too much from the topic, we have selected 3 index cases. One would be a 3 centimeter pelvic calculus, another would be a 1.2 centimeter lower calyceal calculus, and another is a patient who has got bilateral multiple small asymptomatic renal calculi. Now, irrespective of the type of clinical scenario provided, the evaluation of renal calculi basically remains the same up to a point for all patients. So basically in this presentation, what I have tried to do is to tell you about the initial evaluation for all patients, then tackle the management of each of these 3 briefly, and then go on to probably what I consider is the most important aspect of renal stone management, which is a metabolic evaluation and recurrence prevention, which is something which we sometimes neglect in our clinical practice. And therefore, candidates have difficulty in answering these questions in the MCH examination also, MCH and DNB examination as well. So there are various steps which are involved in the evaluation of renal calculi. Some of these steps, as I said earlier, are common, and some of them are selectively used depending on the clinical scenario. The overall evaluation is influenced by various factors, which include the age, clinical presentation, whether it's an acute presentation, chronic presentation, whether the patient has got any coexisting morbidities or any other associated medical conditions, and so on. The different steps include, of course, a thorough history and focused examination, various imaging modalities, the biochemistry, which includes blood tests and urine studies, analysis of the stone, and metabolic evaluation. So starting with the first things first, history is something which is very important both for management as well as for your examination point of view. These are briefly the components of history which is relevant to urinary calculi or renal calculi. A review of symptoms, a comprehensive medical and surgical history, a dietary history, relevant family history, and a focused examination. Symptoms, I'm sure all of you are dealing with these patients on a day-to-day basis, so you are aware of how to take history for symptoms regarding the pain, intensity, location, duration, associated symptoms, and so on. And of course, most of these patients would have recurrent stones at some point. So previous history of any interventions done, any events related to urinary calculi, what was done, whether any dietary advice was given, whether any medical treatment was given, whether the stone was analyzed, all this should be asked for in the history right at the beginning. And then comes the part of complete medical history. This is where many a times residents struggle in the examination because there are so many conditions which are associated with the stone formation. So you should know at least the important associations which exist. So conditions like obesity, metabolic syndrome, which has been, and all these studies quoted at the bottom of the slides, if you can please pay attention to them, they are not merely for reference, but they are also meant to provide you as a guide, which you can quote in your examination when you give answers. Why are you saying what you're saying? So these are all important studies which have been selected in order to support the statements which have been made in the slides. So ask for all the medical conditions which can have a correlation with the stone formation. Some conditions have got a bidirectional association. For example, patients with diabetes or hypertension, they are not only at a higher risk for stone formation, but stone formers are more likely to develop these conditions. So it's a two-way association. Similarly, bowel disease, which may be anatomical or physiological, variety of bowel diseases like Crohn's, ulcerative colitis, bowel resection, they can all lead to an increased stone formation because of various factors like decreased citrate levels, low pH, hyperoxaluria, conditions like conditions related to calcium. For example, patients who have got increased absorption of the calcium, absorptive hypercalciuria, for example, in sarcoidosis, or gout, which has got diagnosed condition of hyperuricemia along with hypercalcemia. It has got a good association with hyperparathyroidism. Then other conditions which can have hyperuricemia, like patients who are on chemotherapy for myeloproliferative disorders, or patients with less absorption leading to hypercalciuria, hyperphosphaturia. Then distal RTA, renal tubular acidosis, which is especially important for renal calculi formation, is the type 1 RTA. Then a long list of hereditary diseases which can have renal stone formation, which include things like cystinuria, primary hyperoxaluria. I will come to this when we discuss the family history part. And then, of course, any abnormality in the urinary tract itself, whether lower tract or upper tract. For example, patients who have undergone diversions, or patients who have got horseshoe kidneys, PUJ obstructions, medullary sponge kidneys, they have all got a high propensity of renal stone formation. So all these things have to be asked for in the history. The history of any surgery in the past for renal calculi, whether patient has got undergone any other procedure, example urinary diversion, or non-urological surgeries like bariatric surgery, where there is a high incidence of hyperoxaluria leading to stone formation. Another important component of history taking is the drug history. Drugs can produce renal calculi in two ways. Either the drug itself or its metabolite can lead to crystallization in the urine and lead to formation of calculi, or drugs can produce certain metabolic changes in the body which can lead to increased formation of renal calculi. And there is a long list of drugs. You must be familiar with some of them. For example, indinavir or triamterene, which are known to cause renal calculi. But then there are a lot of other drugs which examiners are sometimes fond of asking in examination. For example, ciprofloxacin or diclofenac, ephedrine. These drugs can also lead to stone formation by themselves. And then there are drugs which can cause metabolic changes leading to stone formation. Important ones, sorry, important ones are diuretics. So whether it is furosemide, thiazide diuretics, they are most commonly used. And drugs like alkalizers, soda bicarb, potassium citrate, ammonium chloride, all these drugs can produce metabolic changes in the body. So you have to ask the patient about intake of any of these drugs in order to find out their association. Then dietary habits. In examination, often when you present a long case, in the history, you say patient takes a mixed diet, vegetarian and non-vegetarian, and you move on with it. Well, that kind of thing is not sufficient when you're talking about renal calculi. Dietary habits of any patient are a very, very important etiological factor for stone formation. And this has been shown in very good quality randomized trials. The one I have quoted here was published in NEJM, and which showed between two arms of patients receiving different diets, how diet can influence stone formation. Specifically, things that you should ask for are the patient's fluid intake, dietary salt, how much salt approximately he or she takes, history of animal protein intake, uh, calcium and oxalate containing foods, intake of citrus fruits, and various supplements. There is enough evidence in the literature to show that patients who consume less fluid or high sodium diet or high animal protein diet or high oxalate containing foods, they all are at a higher risk of developing renal stones. Then in the current era of weight loss, there are various special diets which are now become a fad, like Atkins diet or intermittent fasting or ketogenic diets. They can predispose a patient to stone formation. Various supplements like excessive vitamin C supplementation or vitamin D or calcium supplements have also been shown in studies to increase the risk of renal stones. Now, if you are working in a clinic in your routine practice, the best way would be to ask the patient directly, and which is called as a dietary recall. But if you have got a dedicated stone clinic and you are focusing on renal stone patients, a much better way of asking about dietary habits is a food frequency questionnaire or dietary records. They, of course, will take more time, but they will give you more accurate information. So this is something that you should know about. And this is another aspect, the family history part, where residents often struggle in examination. Examiners are fond of asking which conditions are associated with stones and which run in families, which familial conditions. So it's important to remember that although there is association with so many conditions, but broadly speaking, you can think of disorders in terms of polygenic versus monogenic. Polygenic disorders are those where multiple genes contribute to a single quantifiable clinical entity, and all of those genes have a role to play. So some of the family members can carry some of those genes, but may not develop the stones. So you don't need to go in for aggressive genetic counseling or family tree searching in these disorders. On the other hand, monogenic stone forming disorders are usually either autosomal recessive or X-linked, and therefore they can have an influence on the family members. And it is here that a genetic counseling is important. And this is just a long list of conditions. I don't know if you can read it. It's a very busy kind of table, but try to identify a few of the conditions. And these are all monogenic renal stone diseases. I have just summarized the important ones for on the table on the left. And you should at least remember these conditions in your examination, which are genetically linked stone forming diseases: cystinuria, all types A, B, AB, all three types of primary hyperoxaluria, type 1 RTA, xanthinuria, cystic fibrosis, Lesch-Nyhan syndrome. So these are common conditions which are running in families and associated with stone formation. So this is what you should be aware of. There are certain clues which can tell you whether a patient has got a renal stone on account of familial tendency or is it just an isolated stone disorder. So people who have got early age onset of urolithiasis, people who have got strong history of family history of renal stones, consanguineous marriages, patients who have got very high metabolically active stone disease, for example, bilateral multiple stones, which are happening again and again, conditions like nephrocalcinosis, tubular dysfunction, patients with renal failure, and then certain particular types of stones, for example, cystine stones, xanthine stones, calcium oxalate monohydrate. So these should raise your uh, antenna a little bit about possibility of it being a familial or a inherited disease. Then the next component of evaluation is the imaging. Most of the guidelines would agree that non-contrast CT scan is the preferred modality, both for planning the treatment as well as after the treatment for follow-up. However, there are specific scenarios where different imaging modalities play a role. And as an initial screening tool, probably ultrasound is the most important investigation. It's a widely available, cheap, relatively safe investigation, which has got no radiation or contrast hazards. It can identify stones located at most parts of urinary tract, except maybe the middle and upper ureter. And it can also tell you about the degree of dilatation of the urinary collecting system, hydroureter. The sensitivity, of course, of ultrasound is on the lower side, which is around 45%, but the specificity is fairly high, at least for renal stones. Adding a color Doppler to ultrasound gives you an added advantage of finding out the resistive index, which can tell you about the presence or absence of obstruction. And then you should also know about what is called as the twinkling artifact, which has been described in the radiology journals as very specific for diagnosis of renal calculi on color Doppler. So basically, any echogenic foci within the kidney, on doing a color Doppler, there is an array of rapidly changing colors which happens behind this echogenic foci. And that is a very highly suggestive finding for renal calculi. So twinkling artifact is something which examiners often ask in examination. So you have to be aware of that as well. Then X-ray KUB, very, very neglected component probably in today's era, but you should know about it because it still has got a role to play. Compared to NCCT, it can detect only about 50% of the calculi. And if you are planning to have an NCCT, probably X-ray KUB is not required. However, there are certain conditions where X-ray KUB becomes important. If you compare a plain X-ray scout film to a scout NCCT, the plain X-ray KUB is superior to scout NCCT, which sounds surprising, but it has been explained. And the reason is that in order to take a scout NCCT view, you need to use very high amount of KV, which is in the range of 120 to 140. And it is believed that the higher the KV is used, more is the penetration of the rays, and therefore smaller calculi are missed. And so much so that of all the calculi which are seen on a pilot scout X-ray KUB, only about half to 2/3 of cases are seen on scout NCCT. And this limitation becomes more glaring, more apparent as the size of the calculus decreases. So calculi less than 5 mm scout NCCT is grossly inaccurate as compared to an X-ray KUB. The other thing about X-ray KUB is regarding the size. Although NCCT theoretically is believed to be more accurate in measuring the dimensions of the calculi, in practice, this is not the case, and the margin of error for both the modalities is more or less the same. The third thing that we look for when you perform any imaging modality is the density of the stone, whether techniques like extracorporeal shockwave lithotripsy would be effective and how effective they would be. So NCCT has got the advantage of giving you values in terms of Hounsfield units. That is not the case with an X-ray KUB, but an X-ray KUB can give you an idea based on the density of the stone. Stones which appear to be smooth and dense on a plain X-ray are less likely to respond to ESWL as compared to stones which appear rough. And this one study by Dr. Chandok and his group from US looked at this, and they found that for renal calculi which were more than 1 centimeter in size, if the calculus was denser on appearance in the plain X-ray as compared to the 12th rib, the tip of the ipsilateral 12th rib, then the stone-free rates were much lower as compared to when it was not that dense. So it can give you an idea about how likely your ESWL or stone fragmentation procedures are to succeed based on X-ray KUB. This is just for your reference. The most radio-opaque calculi on plain X-ray KUB are calcium oxalate, monohydrate, dihydrate, and calcium phosphate. Poorly radio-opaque are struite stones, calcium apatite, and cysteine. And radiolucent stones are uric acid, urate, xanthine, and drug stones. When you look at in terms of Hounsfield units, it more or less matches with what the X-ray is telling you. Highest Hounsfield units are for calcium oxalate, dihydrate, and monohydrate, followed by calcium apatite, then cysteine, and the least is for uric acid stones. Then coming to NCCT, of course, it is currently the standard for acute flank pain, acute colic. It can tell you a lot of information like stone size, the density. It can pick up stones which are not seen on plain X-ray, like uric acid. But there are certain stones like Indenavir stones which are not picked up even on an NCCT. It can also tell you about the inner structure of the stone, whether it's a lamellated stone, what is the skin to stone distance, how is the surrounding anatomy, and which modality might be probably best suited for that particular patient. However, all of this information is much better obtained with a CT urography. So in cases where you're planning for an intervention, particularly a PCNL or an RIRS, a CT urography might be a better option as compared to non-contrast CT scan, although this is debatable and there can be an argument made against it. But as PG residents, probably the message for you should be that when you're planning to enter the pelvic ileal system endourologically, probably you should know as much of anatomy of the kidney and of the surrounding area as possible before you venture into it. And same is reflected in the current EAU guidelines 2022, that NCCT is good for diagnosis, especially in acute flank pain. However, enhanced CT gives you a much better reconstruction of the pelvic ileal system, much better information about the stone characteristics, and it helps you in planning the treatment. And if you are relying on scores like a stone score or a Gaius score, which helps you in predicting the complexity of PCNLs, then probably an enhanced CT scan would be mandatory. That is not possible by doing a non-contrast CT. IVU is getting replaced very fast by CT scan, but there is still a place for IVU in scenarios where, again, you want to know the anatomy. Patient is being planned for surgery. Anatomical detain can be obtained on table by doing an on-table retrograde pyelogram. But many places IVU still is being performed, and so it is not completely obsolete as yet. However, it has got its own issues like use of contrast media. It takes a long time, takes resources, and compared to ultrasound and plain X-ray, it's still an expensive investigation. So limited role, but yes, it is there. MR urography for renal calculi is not a very good modality. It can help you in picking up presence or absence of obstruction. especially in cases where a CT scan may be contraindicated either on account of radiation exposure or where contrast cannot be given, or for some reason CT scan cannot be performed. So MR urography can tell you about the obstruction. However, its pickup rate for urinary calculi is much less as compared to NCCT. So this is a summary of the guidelines for imaging in urolithiasis. NCCT is preferred, strongly recommended based on good evidence. Plain X-ray superior to scout NCCT. Some places IVU is still useful. Addition of color Doppler to ultrasound can help you by giving you restive index values in finding out about obstruction, and very limited role for MR urography, except when you are thinking of picking up obstruction, which is not possible by other means. Regarding follow-up imaging, I have just included a slide here to complete the imaging part in one go, although this will come later on when the stones have been managed. But just to complete the role of imaging, how frequently and which imaging should be performed in the follow-up of patients with stones, this is not clear. There is no unanimity about it. Most of the times, based on very weak evidence, the guidelines would recommend that for a first-time stone former, especially calcium oxalate or calcium phosphate, patient who does not have any other predisposing factors, probably you don't need a follow-up imaging. However, most of the adult patients who have got a radio-opaque calculus, probably an annual X-ray KUB should be done, whether they are a first-time or a recurrent stone former. Patients who have got recurrent stone former, once they become stone-free, yearly X-ray KUB should again be performed. For children or patients who have got uric acid or cystine stones which are poorly radio-opaque, ultrasound is the preferred modality for follow-up. And depending on individual patients, this follow-up protocol may vary. When there's a high metabolic activity, more frequent imaging can be performed. Then comes the role of urine evaluation, a very important part of evaluation, and again something which residents struggle with during exams because it's such a basic test, but it gives you a lot of information. So besides the obvious things like presence of RBCs and pus cells, which is seen in any patient with calculus, other things which are important is presence of crystaluria. Now, it's controversial because crystaluria can occur in normal patients as well, except cystine crystals, which if they are present, should raise a red flag. Then you should probably diagnose or work up the patient more intensively. At other times, presence of crystals can be merely incidental. But there have been many studies which have shown that patients who show presence of crystals in their urine and have received treatment for renal calculi, the recurrence rates are much higher in these patients as compared to those who do not have crystals. So you should still keep an eye out for the presence of crystals. The most important parameters in urine analysis are the pH and specific gravity. Specific gravity, because it's a surrogate marker for the state of hydration of the patient. It can tell you what is the patient's fluid intake usually is like. And pH is very, very important in formation of calculus. So many of the treatment modalities are targeted towards changing the urinary pH. So these two are quite important as far as urine evaluation goes. And of course, urine culture and sensitivity, wherever infection is suspected or you're planning any invasive treatment, should be done. These are the recommendations from EAU. Based on weak evidence, this should be performed. Then the next part is the laboratory analysis, the biochemical workup. Now, basic biochemical workup is more or less same for all patients. However, on selected patients, based on their findings and their metabolic activity, a more specific evaluation needs to be performed. So the basic metabolic profile which should be performed includes serum creatinine, uric acid, calcium, sodium, potassium, CBC, and CRP as recommended by EAU. And in patients where you're planning an intervention, also do an INR and PTT, APTT. What it is missing from this list is two things. One is probably a blood glucose level, which especially in a country like India should be performed more or less for all adult patients, and phosphorus values. Now, why phosphorus becomes important is it gives you a clue about renal phosphaturia, which is an important component of hyperparathyroidism, and can also give you an idea about the renal tubular acidosis. So based on the basic metabolic profile, what information you can get is you can get an idea about the renal function. You can get an idea about RTA. hyperparathyroidism, which although uncommon, but is a very important component of stone workup. And of course, patients who have signs of sepsis or who are being planned for intervention, a CBC along with blood culture, if required. Coming to our three index cases and the management part. The first case, I'll deal with them very briefly because these are clinical scenarios which you must be dealing with on a daily basis. So I'll not take too much time over here. Just to brush up your knowledge, the indications of surgical treatment of renal calculi, this you must remember. Stone growth, what is called as the metabolically active stones, which are growing. Patients who are at high risk, which we'll discuss later, if they develop stones, then stones along with obstruction, stones along with infection, stones producing symptoms, large stones, or if the patient desires because of either his occupation or because of social reasons, then all these are indications for surgical removal of calculus. So our patient has got a 3 centimeter renal pelvic calculus. Based on the guidelines, there are three options. One is a PCNL, other is an RIRS, and the third is extracorporeal shockwave lithotripsy. How do you choose out of these three which is suitable for our patient? The guidelines are very specific. Stones more than 2 centimeter size in the kidney, the first choice should be PCNL. Second choice is RIRS or shockwave lithotripsy, and this is backed by strong recommendation. Now, I'll just like to quote few studies so that you can justify your choice in examination. Now, shockwave lithotripsy, the stone-free rates go down as the stone size increases. And this has been shown in some high-quality studies, some meta-analysis, as well as a Cochrane database review. So you must remember these 2 or 3 references which have been quoted, why lithotripsy is not a very good choice for a 3 centimeter pelvic calculus. Same thing is true for RIRS. As the stone size increases, the stone-free rate decreases, the chances of undergoing a second procedure increase. And this is again based on systematic reviews and high quality studies. I've just quoted 2 of them here. So based on these studies, these recommendations have been made that for a 3 centimeter renal pelvic calculus, probably PCNL would be a good choice. I am not venturing into that to the territory of laparoscopic and open pylolectomy because I don't think that is required at this stage. They are all required for very highly selected cases. The second patient, our index patient, has got a 1.2 centimeter lower calyceal calculus. Now, according to the guidelines, all lower calyceal calculi which are between 1 to 2 centimeter, there are 3 options. Either a shockwave lithotripsy or a retrograde intrarenal surgery or a PCNL, which may be a mini PCNL or a standard PCNL. How do you choose? If the patient has got unfavorable factors for shockwave lithotripsy, and what are these? These are related to either anatomy of the PCS or to the stone factors or to the patient related factors. So if the infundibulopelvic angle is acute, or if the calyx is long, or there is a long skin to stone distance with a narrow infundibulum, or some stones which by their virtue of their composition are relatively resistant to ESWL, like calcium oxalate monohydrate or a cystine stone. If any of these are present or very obese patients, then probably lithotripsy should not be performed. So based on all these unfavorable factors, you take a decision. If they are not present, a shockwave lithotripsy can be a good option. If they are present, then endourological techniques probably are better. Whether to go in for RIRS or for PCNL, it largely depends on what you choose, what you are familiar with, and how you are trained. And this is again a few studies which have led to these kind of recommendations. And these are all relatively recent, 2019, 2020 published systematic reviews and meta-analysis. So you can quote them while you justify your decision to perform this. And the last index patient is one who has got bilateral small non-obstructing asymptomatic calculi. Now, this is a controversial area because there are no clear-cut guidelines which define how we should proceed. The natural history of these calculi is not clear. How many of them are likely to progress to larger calculi is not defined. What will happen to them in the long run is not clear. The various options which are available for treatment are: one is conservative treatment, simply observe the stone. Second is dissolution treatment or chemolysis. And third is the active stone removal. So few helpful studies which are available. One prospective randomized trial said that patients who have got asymptomatic calicial stones which are less than 10 mm in size can be observed annually. That means you do an imaging annually. And if the stone is growing in size, either you intervene or you reduce the frequency of follow-ups, do it at a much higher level. For stones which grow more than 5 mm in size within a year, probably should be removed and intervention should be performed. Systematic review which dealt with the similar type of calculi, uh, the natural history was given according to this systematic review. So if the patient has got non-obstructive small asymptomatic calculi, the spontaneous passage rates can be 3 to 29%. The development of symptoms can be seen in 7 to 77%, a huge range. Stone growth can be seen in 5 to 66%, and surgical intervention requirement in 7 to 26%. So it does give us some figures, but then again, there is such a wide range which is mentioned. It's difficult to make up the mind. So probably you should look at the patient overall, whether he is a recurrent stone former, whether it's a solitary kidney, whether the stones are growing rapidly, how symptomatic he is, how worried he is, whether it is interfering with his profession, for example, whether he is a pilot or whether he is to go to military services where stones can be contraindicated. So based on all these factors, a call can be taken. But for most purposes, these patients can be observed and routinely follow-up should be done. Now, once the stones have been removed, then comes the critical part. And this is the last part of my presentation. This is something which is often neglected. How do you ensure that the chances of patient having a recurrence subsequently or recurrent stone go down? So what can we do in that regard? First thing to do is assign the patient to a low risk or high risk category. In order to do this, you need two things. One is the stone analysis. The stone which has been removed should be analyzed in a laboratory. And second is a basic metabolic workup, most of which has already been done in the past. So based on these two parameters, the patients are assigned to a high risk or a low risk. If it's a low risk stone formers, general measures which are suitable for every patient should be prescribed. If it's a high risk stone former, then there are certain additional metabolic evaluation tests which should be done. So most important component of metabolic evaluation is the stone analysis. It helps you in so many ways. It tells you about the type of stone. It directs you about the further treatment which can be given. It can help you regarding the dietary advice which can be given to the patient. So it's strongly recommended that all stone formers, all first-time stone formers should undergo a stone analysis. A repeat analysis should be performed in certain scenarios. For example, patient who is on drug therapy or medical therapy and develops a recurrence, or patient who has undergone an intervention with complete clearance and develops an early recurrence, or just the opposite, patient who has undergone an intervention, had remained stone free for a very long time and then develops a late recurrence. So in all of these cases, a stone analysis should be repeated. The various techniques, there's a long list of techniques which can be used for stone analysis. The two most important ones are X-ray diffraction crystallography, XRD, or a Fourier transform infrared spectroscopy, FTIR. These are the two techniques which are worth remembering and worth mentioning in your examination. Both of these techniques focus on identifying and quantifying the crystalline component of calculi and not the other macromolecular components. While XRD is a semi-quantitative technique, which means the relative amounts of different components of the stone, they are listed in ranking order 1, 2, 3, 4. FTIR gives you the percentage of various components within a calculus. So both of them are quantitative. One is semi-quantitative, and FTIR is fully, it gives you in percentage how much stone is formed of what. Both techniques are good. However, a lot depends on which laboratory is performing it, what kind of library do they have for comparing these stones to their existing databases, and how well these techniques are being performed. Sometimes in cases of mixed stone, both of the techniques have to be performed together in order to get an accurate picture. The oldest technique of stone analysis is now obsolete, which was done in most of the urology labs across different institutes. We used to do it in our lab till 10 years back. That is called as the wet chemistry or the chemical analysis. That is no longer done. So the importance, as I said earlier, a stone analysis can tell you about which dietary advice to give, which specific medical therapy to be chosen in order to diagnose what are the associated medical conditions which can lead to stone formation. Then there are certain special stones which are associated with, for example, calcium apatite, strong association with primary hyperparathyroidism and RTA. Similarly, uric acid stones associated with hyperparathyroidism as well as hyperuricemia and gout. So all this information can be obtained from a well done stone analysis. So strongly recommended as far as EU guidelines go, all first time stone formers and selected second time stone formers or repeat stone formers. So based on stone analysis and basic evaluation, now you can categorize the stone into high risk or low risk. And this table on the left, again, a very busy table, lists a long list of factors which categorizes these patients high risk stone first. General factors, then various presence of various diseases, then genetically determined stone forming factors, drug induced stone formation, various anatomical abnormalities, and various environmental and professional factors. So presence of these factors along with stone analysis can help you in categorizing these patients into a low risk versus high risk. The last part is regarding the 24-hour urinary studies. Again, something which residents struggle with in examination because this is slightly confusing to understand, and most centers do not practice it actually. So the residents are not really exposed to this kind of evaluation. So where they should be done in all high risk stone formers, especially recurrent stone formers, all patients with cystine stones, and then certain patients who are first time stone formers, for example, children or patient with solitary kidney. Now, solitary kidney does not mean that the patient has got a high metabolic risk, but the kidney is precious. So we want to be doubly sure that the patient does not get renal stone in future. Or patients who have got severe renal insufficiency, bowel diseases, or professional reasons like commercial pilots. So a 24-hour urinary evaluation has got a high probability of picking up certain abnormalities, metabolic abnormalities, for example, hypercalciuria and hyperoxaluria. And more importantly, there are specific effective treatments which are available for these conditions. So that is why the role of 24-hour urinary evaluation becomes even more important. Now, whether it should be done on a controlled diet or on a random diet has been a matter of debate. But currently, most of the people would agree that for the first time, initial metabolic workup should be on a random diet, which the patient is taking anyway on his usual diet. And however, patient should be stone free, and this stone free status as recommended is about 3 weeks. So patient should be stone free for at least 3 weeks before he is subjected to a 24-hour urinary analysis. Certain practical issues which can be asked in examination to you: the container should be large enough, at least 4 liters, so that all the urine can be accommodated. It should either be stored at a temperature of less than 8 degrees, or it should have preservatives like a 5% thymol or boric acid. Most of the good laboratories provide these containers themselves, and they have got these preservatives already added to them. So that should be taken care of. Whenever the urine is being added to that container throughout the day, a urine pH should be measured and noted down. In some category of patients, for example, very small children, collecting a 24-hour urine sample may not be possible. So laboratories do advise a spot urine sample to do similar kind of analysis, but of course, it is not that accurate as a 24-hour urine analysis. The parameters which are measured in this 24-hour urine analysis: the volume, the pH, the creatinine. I'm reading it one by one so that you realize the importance of these parameters. You should remember them. The volume total over 24 hours, the pH, the creatinine values, calcium, uric acid, oxalate, citrate, magnesium, phosphorus, sodium, potassium, ammonia, blood urea nitrogen, and sulfate. And there is a reason why all of these have to be measured. The creatinine measurement, 24-hour urinary creatinine measurement, tells you about how accurate the collection is. And these are the reference values for males and females for a 24-hour period. Then measurement of calcium, citrate, uric acid, pH. It can tell you about different conditions like hypercalciuria, hypocytituria, hyperoxaluria. Magnesium and sodium are indicators of what is the overall salt intake of the patient. The blood urea nitrogen, sulfate, phosphate, and uric acid are indicators of protein consumption. And cysteine, of course, indicates cystinuria by itself indicates a pathology which needs further investigation. The reference ranges for all of these vary widely in males and females across different age groups and as per body weight. So I have deliberately not given you a table here because that gets even more confusing. There is a wide range of values which have been provided for different groups. Whether a single 24-hour sample is enough or whether two consecutive samples should be connected is again a matter of debate. It has been observed that, and by various researchers, including leading names like Parks and Park, who have shown that there is a lot of variation from one day to another day, especially on a patient who's on a random diet in these 24-hour urinary parameters. So therefore, most of the people would recommend a 2 consecutive 24-hour urinary specimen collection in order to get more accurate results. However, there have been few studies like the one quoted here, where these authors have shown that there is a remarkable degree of similarity between the two samples of the 2 days, 2 consecutive days. So they say that one day is enough because it more or less reproduces what the other day is going to show you. But currently the guidelines recommend a 2 consecutive 24-hour urinary sampling. And of course, the kind of stone which you picked up on your stone analysis, which was performed earlier, will influence the what kind of testing needs to be done on this urine sample. For example, patients who have got pure white stones, you don't need a 24-hour urinary testing because you will hardly pick up anything. The pathophysiology is quite clear-cut in case of white stones. So the aim of treatment is mainly to achieve a stone-free status and to avoid any future UTIs. However, in patients who have got a mixed white stones, where there are other components mixed with white, then the testing is required, as a significant number of patients may have certain metabolic abnormalities and treatment may benefit them. Patient with pure cystine stones, there you don't need to evaluate everything which was told earlier, and you can limit it to measurement of urinary volume, pH, presence of cystine, and creatinine. In mixed cystine stones, of course, a complete panel has to be measured. Similarly, for pure uric acid stones, you just need to measure the 24-hour urinary volume, pH, creatinine, and uric acid. But in case of a mixed stone, again, a complete panel has to be measured. Lastly, about the follow-up studies, should it be done only once or do you need to repeat a 24-hour urinary evaluation? Patients who are put on specific diets or specific medical therapies, they should undergo a repeat 24-hour urine analysis, and it should ideally be done 6 to 8 weeks after the therapy is started to show whether the therapy is working or not. If the therapy is not working and the patient continues to show metabolic abnormalities in this 24-hour urinary sample, then consider changing the treatment, either the agent itself or the dose of the medicine which is being given, and repeat a analysis after another 6 to 8 weeks till you find the right combination which is benefiting the patient. If on the first repeat analysis, you see that the urine changes are as on the expected lines which you were expecting them to be, then you don't need to repeat it any further. Continue the patient on same medical management, same dietary advice, and do a yearly analysis, annual analysis. If in between the stone activity or the metabolic activity is high, then this study can be repeated more. Lastly, the guidelines about urine analysis, of course, should be performed on all patients. I don't know why it is based on such weak evidence in the guideline statements. Almost all of us would agree that it's a very, very important component. If infection suspected, of course, urine culture should be obtained. The 24-hour testing should be reserved for recurrent stone formers, cystine stone formers, patients with precious kidneys, or for professional reasons, and in children. It should be collected on a random diet. What should be tested depends on the stone analysis report, what kind of stone was found, and ideally 2 24-hour urinary samples should be collected. So to conclude, when you manage a case of renal stones, multiple factors are involved, starting from the age of the patient, sex of the patient, primary versus recurrent, metabolic versus relatively isolated stone, uh, whether patient has got any other coexisting conditions which could affect urolithiasis. Currently, the most effective measures to take care of the stones are, of course, endourological as well as lithotripsy. After the patient has been cleared of stone, he should be evaluated for the risk of recurrence, which includes a mandatorily analysis of the stone which was removed. And in patients who are found to be at high risk, after the stones have been cleared, a detailed metabolic evaluation should be done, and accordingly, a tailored dietary as well as pharmacotherapy should be started. Thank you very much.
Yeah, thank you, Smear. It was a very crisp and very erudite presentation. I think these slides were all packed with so much of knowledge and information. And I'm very sure that all agents would have enjoyed. Now, let us go to the chat box. And if you can answer the few doubts from our agents. Let me come to Dr. Prithvi's. He wanted to know the role of metabolic workup in small renal calculi. Probably let us take a situation of you have a non-obstructive small renal calculi one side or both the sides. Would you advocate metabolic workup?
You want me to take that, sir?
Yeah.
You want me to answer that, sir?
Yeah. Yes, yes.
So, yeah. See, bilateral small calculi, lot would depend on the specific scenario in which they have been found. If it's a patient who has been forming these stones again and again, then probably metabolic workup is strongly recommended. If his basic biochemical profile is indicative of an abnormality, then a complete metabolic workup is indicated. The problem with bilateral small renal calculi is its correct diagnosis. We rely on ultrasound to make the diagnosis of these small calculi, and ultrasound is often very fallacious and observer dependent. Lot of time, small calcific foci or echogenic foci in the renal parenchyma has been reported as stones. So make really sure that it is really a renal calculus, and presence of bilateral renal calculus otherwise indicates a strong stone forming tendency. So at least a basic metabolic profile should be done, if not a comprehensive evaluation.
We have a second question from Anshuman. He wants to know for stones on the size of 1 to 2 centimeter lower pole, shouldn't the miniaturized technique of PCNL like SMP or miniaturized PCNL should be used, or whether they can be brought into the guidelines? Because if the
Yes.
guidelines says PCNL. Yeah.
Yeah, Anshuman, I think your point is well taken. The guidelines already consider them to be the preferred modalities. The only thing is shockwave lithotripsy has been mentioned with a long list of caveats, that if this is not there, this is not there, this is not there, this is not there, then shockwave lithotripsy can be considered. So for that limits the field to very, very selected stones which are suitable for shockwave lithotripsy as a first line therapy. I agree with you. Endourological procedures, be it RIRS or be it mini PCNL, they have got a very high success rates, and they have got a complete stone-free rate in single sitting. Of course, there is a risk of anesthesia and other things which are there, which is not the case with ESWL. So probably a thorough counseling and discussion with the patient before you take a call regarding the success rates as well as the complications which do happen.
Samir, I'll go to Dr. Suleiman, who has raised his hand. Dr. Suleiman, please unmute yourself and you can ask the question. Dr. Suleiman. I think we'll go ahead to the next question. This question is from Manu. The question here is regarding to the statement which we have given regarding metabolic evaluation. The opinion is that Park references concluding that one sample is inadequate. Your comments on that?
No, what I understand from the question is Anu is saying that the park. Do you mean park or park? There are two scientists. One is PARK park and one is PAK park. So the reference which has been shown here is the park reference.
Is
It
it
is not
PAK?
park.
It should be correctly PAK. The park has the maximum articles on metabolic evaluation.
Yeah, so I quoted the park reference and he has got multiple publications. The one which I quoted was the Journal of Urology 2001 paper, and that paper was titled whether adequacy of a single 24-hour urinary sample for metabolic, something like that. So in that he argued that a single sample is enough because if you take two samples on two consecutive days, the findings are more or less likely to be similar. So that reference is in that regard. So there is some confusion about that. Yes.
Yeah. I think, yeah, we are no more question in the chat box. The point of what you are making single, I think we have many abstract which have got published in and probably on the presentation made by 6 hour urine collection metabolic for the metabolic equation. So all are there. There are different ways, but the idea is the best way is you should have a tool which has the more better sensitivity and specificity to predict the underlying abnormality. But because it's a cumbersome, you need a big bottle, 2 hour patient right giving sample and all that, and patient has to stay indoor or take the bottle in the house and bring it to the lab. So it's not easy. In Indian scenario, I think all these steps are easily bypassed in favor of just getting a stone analysis and bringing the preventive strategy in place after seeing the stone analysis. So that is way, but for stones, if you have to see, there are various research-based level 1 evidence strategy, which courses. But again, people are modifying this and you get the maximum yield which they can get. So that's what he has quoted. But if you see the from the slide 1 to the last slide, you had the reference to all the statements which he has made, which included EU guidelines. So I think this was a very, very see, every slide was loaded with so much of information. If you focus on this today's webinar, which will be there in 3-4 days in the YouTube, just go and revise it again. I think you will be able to satisfy every examiner what is question posed on urocystis. Every doubt has been cleared. Guideline-based management for common scenarios has been covered. The idea was not to cover the PCN and how you do the idea the URS, but everybody wants to know the concept. The concept of evaluating and managing the stone has been discovered very nicely with the now I'll go to one more question. Is there bilateral kidney stone with DJ stent with creatinine 3 on count, which was earlier 5 on account of sepsis? How to proceed? So this is something related to intervention, probably management. So Shamir, can you take that question? So patient with the stones and sepsis, creatinine was 5, bilateral DJ stenting done, creatinine is on the decline, it has come to 3. Now how to proceed? We don't know whether it's nadir creatinine. Let us assume that it is 3, around 3. It is after 7 days or 2 weeks. It is steady.
Yeah. So probably what he's suggesting, it's a case of CKD. There is no hydronephrosis as he has mentioned. So probably it's a case of chronic kidney disease, and he has got bilateral stones with DJ stent. I don't know whether DJ is bilateral or unilateral, and we are not sure about the size of the stones as well. But in any case, patients who are of CKD patients with stones, every effort should be made to make them stone free. So depending on the type of stone, the location of stone, whatever intervention is suitable for them should be done, and the DJ should be out at the earliest. Presence of DJ without any hydronephrosis does more harm to the patient than any benefit. So if there is no obstruction, DJ has got no place to be inside the patient's body.
Venugopalan wants to know about how much water intake should be devised for cystine stones. I don't know pure cystine stones in India whether we find it, or, but anyway, your take on that.
Yeah, I was wondering if somebody would ask that question. See, Venugopal, excellent question, because I'm sure you must have done some study about it. You must have read about it. See, in general, for any stone former, when you give a dietary advice or advice regarding fluid intake, it is not the amount of fluid to be taken which is important. It is the amount of fluid which is going to come out of the body. So, what should be the target urinary volume which should be there for a patient? So at least 1.5 to 2 liters of urine should be formed in a day. For that, somebody may have to drink 3 liters and somebody may need 4 liters, depending on the kind of environment that they are living in, the kind of work that they do. Cystine stone is one where diuresis is probably the most important. In fact, there is a term called as hyperdiuresis, which is used specifically for cystine stones. And in hyperdiuresis, the target is to produce 3 to 4 liters of urine per day. And that is meant specifically for patients who are not responding to other conventional treatments of cystine stones, for example, thiol or penicillamine and those things. There, this kind of hyperdiuresis is prescribed. So at least 1.5 to 2 liters of urine output, whatever water is required for that. And in refractory cystine stones, target urinary volume of 3 to 4 liters. I hope that answers your question.
Yeah, absolutely right. It depends upon if you're working in a hot, humid climate, you need to take more to get 1.5 liter of urine or 2 liter of urine, which may not be there in if you're working in AC or an office job. So all things are to be taken into account. But what I am impressed with is bringing very subtle points, important and subtle points. See, the most of the time you get caught in urine examination
Yes.
and X-ray, and he has made these 2 points amply clear. How much is the importance of this? How you see the pH, how you find the crystal, how what is the microscopy important, and X-ray. This is in the era of NCCT. I think everybody skips over this X-ray. There's ultrasound and straight away go to NCCT. And I think the X-rays, the role of X-ray in the evaluation as well as planning the treatment strategy, he has brought a lot of the points in favor of X-ray. And sometimes they will say that NCCT is scout film, which is a tomogram film, and that I can make an impression. That cannot substitute the X-ray KUB. A well done X-ray KUB. A lot of information to. So I think we don't have many questions now. On behalf of Indian School of Urology, thanks to Dr. Samir for sparing your time for our agents. I think we'll see you soon again, maybe next year for the when we are making the program for the next year, academic year. Thanks to all the agents who logged in for this program, and I think I must watch this program 3-4 days after when it is put on the YouTube and the USI TV. Thank you, Samir, once again on behalf of USI. Dr. Keshav couldn't, he was busy, but he conveyed his thanks to you. Thanks on behalf of USI also, and thanks on behalf of all the agents also for taking the. Thank you. Good night.
Thanks for the opportunity. It was a pleasure for me, and I hope residents learned something. It's great.
Yeah. Thank you very much.
Thank you, sir. Thank you.
Bye. Good night.
Thanks, everyone. Bye, sir.